Welcome to the exciting world of narrow complex tachycardia and SVT. In today's sketch, we'll talk about some of the different causes of a narrow complex tachycardia and learn some electrophysiology and how to evaluate and treat these patients. And what better place to talk about narrow complexes than at a dog show complex? Actually, maybe there is a better place. But here's the better question. When I say narrow complex tachycardia, how tacky and narrow are we talking here? Well, on the ECG, first evaluate the rate. The normal resting adult heart rate should be between 60 and 100 beats per minute, although sometimes it's much lower in a healthy young patient or in athletes. Tachyarrhythmias are abnormal rhythms with a ventricular rate over 100. Next, decide whether this tachycardia is narrow or wide complex. If the QRS complex is less than 120 milliseconds, in other words, less than three little boxes, each equal to 40 milliseconds, it's classified as narrow complex. Easy peasy. Well, not the P, but easy QRSy. Notice the dog show logo here. The beam of light is like the QRS spike, and it's narrower than the three boxes of the podium. We care about the width because it tells us if the beat passed through the AV node to hit the conduction system of the ventricle, which creates a narrow QRS. A wide QRS complex develops when the beat takes a sneaky shortcut to get to the ventricles, or if the beat originates in the ventricle itself. This is all covered in our wide complex tachycardia sketch over at the police station. Remember that the QRS complex represents ventricular depolarization and that the duration of the QRS complex is the amount of time it takes for the ventricle to depolarize. If our electrical current is flowing from the atrium through the AV node and down the normal conduction system of the heart, this is the fastest way for the heart to depolarize and should take less than 120 milliseconds, creating a narrow complex. So we assume that any narrow QRS complex originated above the AV node and thus is supraventricular. Super. Now that we've identified a narrow QRS tachycardia, it's time to look at the rhythm. Is it regular or irregular? Generally, the easiest way to do this is to measure the RR intervals. Well, if you take a look at the notes in the back of this dog show complex, you'll notice that the left side of the sketch will be dedicated to regular rhythms, while the right side will be all about the irregular. It's like frickin' jazz over there. Let's start on the left with the regular rhythms. Signs up awkwardly slant rhymes with the word sinus. You know what I mean? Meant to remind you of sinus tachycardia, the most common supraventricular tachycardia. The sinus part just means that the impulse originates in the SA node and travels down the conduction system of the atrium to depolarize the AV node. Remember that the P wave represents atrial depolarization, so sinus tachycardia can be identified if every single beat has a regular P wave preceding every QRS complex, all of which will be narrow complex. This is why the sign features a P-tail puppy preceding every QRS dress. These P's should also be normal looking, and by that I mean upright in 2, 3, and AVL. Watch out, because when the rate is really fast, it can be difficult to see these P waves. The Valsalva maneuver, carotid sinus massage, or IV adenosine may be used to slow down the heart a bit and spot those P's. We'll show this in action a little later. Conveniently, these maneuvers will also terminate in AVRT or AVNRT rhythm. What's AVNRT, you ask? Well, remember that SVT or PSVT stands for supraventricular tachycardia or paroxysmal supraventricular tachycardia. As we hinted earlier, technically any tachycardic rhythm that starts above the level of the ventricle, including sinus tachycardia, atrial fibrillation, and atrial flutter, falls in the category of SVT. It's kind of like this heart-shaped purse here. All the barks are coming from the atria, and in the setting of SVT, all the beats are coming from above the ventricles. That's all it means. Paroxysmal supraventricular tachycardia is more commonly used to describe tachycardia caused by a reentrant circuit of conduction. In other words, after ventricular contraction, the impulse continues through an extra pathway, reactivating the ventricular conduction system. And the loop continues. So, as this dog fancier here sneaks in through a special reentry point, keep in mind that this extra pathway consists of an accessory pathway away from the AV node, or a reentrant circuit right around the AV node itself. The reentrant circuit of electricity produces a regular tachycardia with a rate generally between 150 and 250 beats per minute. Again, just want to remind you that we're on the regular rhythm side of the room here, hence the regular notes in the back. These tachycardic events are sudden and recurrent, paroxysmal, if you will. Because the impulse does not start at the SA node, there are often no discernible P waves before every QRS. Though, as the circuit loops around back to the AV node, an impulse does depolarize the atria eventually, just not at the time you'd expect on the ECG. In fact, it's often buried in the QRS complex. Just think of this P tailed puppy here with his inverted P shaped tail peeking out of that QRS dress. Blah, who's a shy little P wave? In some leads, you might see so called retrograde P waves that are inverted and popping up at the wrong time. The two main types of these reentrant circuit tachycardias are illustrated over on the doggy obstacle course. Atrioventricular nodal reentrant tachycardia, or AVNRT, pay attention to that N in there, means that the extra pathway is contained within the AV node itself. And the electricity just loops around in there, sending an impulse down to the His-Purkinje system of the ventricle every time it passes by. Which is why that dog is just chasing his tail in a loop within the central AV nodal area of the course. Plain old AVRT, without the N, means that the impulse is traveling down an accessory pathway between the atrium and ventricle, but outside of the AV node, represented by that chihuahua there running from the ventricles back up to the atria on a little bridge shortcut. Orthodromic AVRT means that the impulse travels down the AV node to activate the ventricles, then heads back up to the atria through the accessory pathway, completing the circuit. And notice that he's wearing a cute little ortho harness. Aw, who's my cute little reentrant accessory? Yeah. Cuteness aside, focus on that loop outlined with the arrows. We're heading through the AV node to activate the ventricles. This activates the normal conduction system, creating a narrow, regular tachycardia. Again, that's orthodromic AVRT. When the circuit goes the other direction, antidromic in other words, the ventricles are activated incorrectly and the depolarization is prolonged. This shows up as a wide QRS complex tachycardia and is illustrated by this anti-drone dog over in our wide complex tachycardia sketch. On top of that, the AV node is not able to slow the circuit and the heart rate can get up into the 300s. This can lead to cardiovascular collapse or deteriorate into VFib. Not good. Back to more benign arrhythmias. How about atrial flutter? In atrial flutter, there's generally a reentrant circuit or a single irritable area within the atrium that's firing continuously, usually around 300 beats per minute. On the ECG, you won't find P waves. Instead, you'll see the atrial flutter contractions, or flutter waves, in between each QRS. They're generally described as a sawtooth pattern. The AV node blocks some of these impulses, and others get filtered through, forming narrow QRS complexes as the ventricles get activated. Which is why this fluttering wiener dog is performing lots of little hops, but every once in a while a big jump as she depolarizes a ventricle, if you will. Usually only one of every two signals are transmitted through the AV node down to the ventricle, resulting in a QRS complex. This is called atrial flutter with a 2-to-1 block, and results in a ventricular rate of about 150 beats per minute. Other ratios, such as a 3-to-1 or 4-to-1 conduction can occur as well, with even numbers being more common. If there's no variability to the block, a regular tachycardia develops. But if the degree of that block changes from second to second, which is common as well, it can result in different RR intervals and an irregular rhythm. This is why this dog, with her ears fluttering as she runs, is in front of both the regular and irregular notes in the back. Alright, over on the irregular side of the dog show complex, we're going to illustrate the common narrow complex tachycardias that typically have an irregular rhythm. Think of AFib, a flutter with variable block, or multifocal atrial tachycardia. We already mentioned that whole A flutter variable block thing, so let's move on to AFib. Atrial fibrillation occurs when discoordinated pacemaker cells send chaotic electrical signals from all over the atrium continuously. The atrium can generate over 400 electrical signals per minute, but fortunately, only some of these get transmitted down the AV node. This usually results in a ventricular rate somewhere between 100 and 200 BPM. The most common term that you'll hear over and over again to describe atrial fibrillation is irregularly irregular. This means that the RR intervals are all different lengths with no clear pattern. At Sketchy, we represent this with an irregularly irregular static signal on a TV screen. Notice that in between spikes is just a weird squiggly line. That's because there's no coordinated depolarization of the atria, So we lose the P wave, and you may only see a wavy, erratic baseline between the transmitted QRS complexes. Don't worry, our next sketch is all about them AFibs, what causes the fibs, and how to treat them. The last and least common of the irregular narrow complex tachycardias that we'll be covering is MAT, or multifocal atrial tachycardia. Everything you need to know is right there in the name. In multifocal atrial tachycardia, there are multiple areas of the atrium, at least three, that are all taking turns firing and sending the electrical impulse down through the AV node and to the ventricle. Due to these signals being generated in different areas of the atrium, the P waves look different. Some taller, some wider, and some even inverted. But they'll all be followed by a QRS complex as the ventricle gets the signal from the AV node and contracts. Just think of these P-tailed puppies here eating over the MAT mat. Notice they're waving their P-shaped tails in the air, each slightly different. MAT is characterized by tachycardia, at least three different P wave morphologies, each followed by a QRS, and thirdly, an irregular rhythm. Which is why we're on the irregular side of the dog show complex. The atrial signals don't occur at regular intervals and take varying amounts of time to reach the AV node, leading to irregular RR intervals on the ECG. MAT is usually caused by pulmonary disease, but that's a story for another time. In the next sketch, we'll give you all the details, over on the yoga mat. Alright, now that we have an idea of the different types of narrow complex tachycardias, let's dive into the evaluation and treatment of a patient with paroxysmal SVT, such as AVRT and AVNRT. PSVT can present at any age, from neonates to the elderly. The younger the patient is, the more likely that the PSVT is benign without underlying structural heart disease or scarring. Palpitations are the most common presenting feature, represented here by the announcer clutching her heart necklace. Many patients will also present with dizziness or lightheadedness. Those with underlying cardiac abnormalities may present with chest pain and shortness of breath. Syncope from reduced cardiac output is rare. Some patients will have a history of Wolff Parkinson White, or at least you'll be able to find a previous ECG with the characteristic pattern. This hints at the presence of an accessory pathway. Just think of this announcer lady getting attacked by these Wolff Parkinson White wolves. Are those even allowed? Anyways, what we're looking for here is a short PR interval and a slurred upstroke of the QRS called a delta wave. These features are represented by the falling PR microphone and slurred QRS stress. Think of it this way. See how that wolf jumping down the accessory pathway is hitting the QRS stress before the wolf traveling down the node? Think of that little slur at the beginning of the upstroke as a little pre-excitation from the impulse coming from the accessory pathway, before the real impulse from the AV node takes over and initiates the QRS complex. Keep in mind that these features will only be present in some patients with an accessory pathway, on only their resting ECG in a normal sinus rhythm, not when they're tachycardic from a re-entrant rhythm. Speaking of that re-entrant tachycardia, whether we're talking AVRT or AVNRT, the re-entrant circuit is usually initiated by an atrial or ventricle premature beat. These are associated with some common triggers, including exercise, alcohol, caffeine, nicotine, other stimulants, or other hypermetabolic disorders such as hyperthyroidism. It's only a matter of time for this guy. There are two main goals during your evaluation of the patient with a suspected PSVT. Your first goal is to confirm that this is actually PSVT and not something else such as sinus tachycardia, atrial flutter, or ventricular tachycardia, and this is done by careful analysis of the ECG. As we discussed earlier, the ECG manifestations of AVNRT or orthodromic AVRT include a regular narrow complex tachycardia with a rate in the 150 to 250 range. There will be no discernible P waves or possibly retrograde P waves buried in the QRS complex or popping up in the wrong place. The rate should be fixed. If there's a lot of variability of the rate, you may be looking at sinus tachycardia rather than PSVT. You may also see ST segment depressions, though these are usually related to repolarization abnormalities and not ischemia. Expect them to resolve with conversion of the patient back into a normal sinus rhythm. The second goal is to determine whether your patient is stable or unstable, as this will determine your treatment algorithm. Signs of hemodynamic instability and poor perfusion include hypotension, altered mental status, or acute heart failure, symbolized by the blood pressure cuff, brain cap, and floppy heart balloon. These patients will require emergent and aggressive treatment. The most glaring physical exam finding will be tachycardia with a regular ventricular response. But remember to inspect for signs of heart failure or ischemia, especially in older patients. Assess for chest pain, diaphoresis, dyspnea, leg swelling, JVD, and crackles. Generally, imaging is unnecessary except in the case of heart failure symptoms, in which a chest x ray can be considered. Sample assessment? Don't mind if I do. Mr. Tack is a 35-year-old male with no past medical history presenting to the emergency department with sudden onset palpitations, lightheadedness, and feeling of his heart racing that started about 30 minutes prior to arrival. He reports some mild chest discomfort but denies severe chest pain or shortness of breath. He states that he drinks multiple energy drinks every day but denies illicit drugs or alcohol use. His physical exam is notable for a heart rate of 185, but blood pressure is stable at 115 over 75, and mental status is unchanged. ECG shows a regular, narrow complex tachycardia with no discernible P waves. Given his symptoms and exam, I suspect that Mr. Tack is suffering from paroxysmal supraventricular tachycardia. Alright, plan time. For the unstable patient, our first line therapy is synchronized cardioversion, represented by these synchronized heart watches. No time to attempt vagal maneuvers or obtain and administer increasing doses of medications. Just remember, if the patient is truly unstable and not perfusing their vital organs, they need aggressive treatment right away. And the fastest and most effective way to do that is with electricity. The patient in our sample assessment would obviously fit into the stable category. But if he were a 70-year-old with confusion and severe hypotension, it's zappy zappy time. For stable patients, the goal of therapy is to break the reentrant circuit and restore normal sinus rhythm. The best way to do this is to slow conduction through the AV node, as both the AV-NRT and the AVRT circuits pass through the AV node. Generally, in a stable patient, we start with the least invasive therapy and progress to the most aggressive therapy. The least invasive way to slow conduction through the AV node is by increasing vagal tone or performing what's referred to as vagal maneuvers. This includes carotid sinus massage, as depicted by this dog trainer here, wrangling the carotids of this chihuahua. Be careful in the elderly or in those who have risk factors or known history of carotid vascular disease, in which carotid massage could lead to stroke. In these cases, you might want to start with an alternative vagal maneuver. These include the Valsalva maneuver or dunking the patient's face in ice water. Unfortunately, vagal maneuvers are only successful in a small percentage of patients, and most will go on to require pharmacotherapy. The good news is that we have a safe, short-acting drug that can completely block the AV node, adenosine, represented by this adenosine dancing dog. Adenosine is usually given in a 6 mg bolus push, and if no response occurs in the first few minutes, the dose is doubled to 12 mg. Adenosine blocks the AV node completely, but only for a few seconds, as the half-life is less than 10 seconds. This is enough time to break the reentrant circuit and restore normal sinus rhythm without putting the patient into complete heart block for any significant amount of time. Vagal maneuvers and IV adenosine are not just helpful for treatment, but also for diagnosis. By slowing down the heart, it'll be easier to spot those P waves if there are any hiding among those QRS spikes. So we've made sure their wagging P-shaped tails are visible. Look for flutter waves indicating atrial flutter, sinus P waves indicating sinus tachycardia, abnormal P waves characteristic of multifocal atrial tachycardia, retrograde P waves of AVRT and AVNRT, or no atrial activity at all, which is characteristic of atrial fibrillation or AVRT and AVNRT. Other options for pharmacotherapy include other drugs that slow conduction through the AV node, including the non-dihydropyridine calcium channel blockers, verapamil or diltiazem, beta blockers, or rarely, digoxin. Notice the muted beta bugle and calcium ice cream ad. Our recurring symbols for beta blockers and calcium channel blockers. These agents aren't usually needed in the acute setting due to the effectiveness of adenosine. If the patient is refractory to pharmacotherapy, the last resort is synchronized cardioversion. Although, again, this is rarely necessary in stable patients. Once you've successfully blocked the AV node and the patient has returned to normal sinus rhythm, you're the hero. However, because those accessory pathways still exist, the patient is at risk of going back into SVT again in the future. If the patient has frequent recurrent episodes, long-term therapy consists of chronic calcium channel or beta blocker therapy, represented by our chronic grandfather clock symbol. Surgical radiofrequency catheter ablation may be performed to essentially destroy the accessory pathway and prevent recurrences. Alright, let's take a look at the play-by-play and run through the diagnostic algorithm for narrow complex tachycardia. First, inspect the ECG, of course. Tachycardia means over 100 beats per minute, and narrow complex means that the QRS complexes are less than 120 milliseconds, or three little boxes. Next, is the rhythm regular or irregular? If it's irregular, look for P waves. No P waves and an irregularly irregular rhythm is characteristic of atrial fibrillation. Sawtooth flutter waves are characteristic of atrial flutter. Usually, only one out of every two signals are transmitted through the AV node down to the ventricle, resulting in a QRS complex. This is called atrial flutter with a 2-to-1 block, and results in a ventricular rate of about 150 beats per minute. If there are multiple P wave morphologies, think multifocal atrial tachycardia. Let's say the rhythm is regular. Again, you gotta look for those P waves. If you're having a hard time finding those P's, you can administer adenosine or perform carotid massage in order to slow down the rate and uncover those P's. Look for flutter waves indicating atrial flutter, sinus P waves preceding every QRS indicating sinus tachycardia, abnormal P waves characteristic of multifocal atrial tachycardia, retrograde P waves of ABRT and AVNRT, and no atrial activity at all, which is characteristic of atrial fibrillation or AVRT and AVNRT. And if the episode of tachycardia was terminated by the adenosine or carotid massage, and you find your patient back in sinus rhythm, consider AVRT or AVNRT. Once you're in sinus rhythm, you may detect the classic short PR interval and slurred QRS upstroke characteristic of Wolff-Parkinson-White syndrome. This indicates the presence of an accessory pathway. Alright, if your patient is unstable rather than stable, the algorithm is a bit different. Assess for hypotension, shortness of breath, chest pain, or altered mental status. Definitely unstable. Check that ECG. If it's a sinus rhythm, treat the underlying cause and consider an IV beta blocker if there are signs of ischemia or if the tachy sinus rhythm is inappropriate. If your unstable patient is not in sinus rhythm, it's cardioversion time. Alright, that's it for our narrow complex overview. We gave PST its time to shine, and now it's time to head on over to the old folks' home for the workup and treatment of AFib, A-flutter, and MAT.